you can imagine that if you had a skin cancer the size of a match head on the tip of your nose, you'd see it when you brushed your teeth and you'd be aware of it pretty early. If you had that same skin cancer, that same cancer the size of a match head in your lung, you'd never be aware of it. I mean, it's not uncommon to have somebody come in with a cancer the size of a softball in their lung, and they're just starting to become aware of it. And by that time, the cancer's grown enough that it's often spread.
Welcome to Creepalachia. I'm so honored to be joined by another professional in the world, and today we are talking about the ins and outs of cancer and what that involves with Dr. David Shimm. Thank you for joining us, sir.
My pleasure.
So you're in the radiation oncology department or how does that work?
Yes, that's exactly right.
Okay, gotcha. And what does that consist of? Like, what's like kind of an overview?
Okay, well, an oncologist is a physician who's concerned with treating cancer. A surgical oncologist is a surgeon who operates on cancer. A medical oncologist treats cancer with chemotherapy, and a radiation oncologist treats cancer with x-rays.
Gotcha. Well, that's pretty simple. So we'll go into some background. So to give people an idea of the expertise here and how unqualified I am to have this conversation, but I'm going to try and ask good questions.
Okay.
So it says here, so you're a Harvard undergrad.
That's correct.
Yeah. 1973, you went to Duke University School of Medicine in 1977, in 78 and 80.
Well, I graduated medical school in 77.
Gotcha.
Finished my internal medicine residency in 1980. Finished my radiation oncology residency in 1983.
And then we got, and that was at Massachusetts General Hospital in 83?
That's right.
Sweet. So tell me about you. What's your backstory? Where'd you grow up?
Grew up in Durham, North Carolina. My dad worked at Duke. Had a pretty uneventful childhood, to be honest.
Why you say uneventful? Just, went to school, went home, did your homework.
Yeah, I mean, honestly, not a whole lot of tragedy, not a whole lot of relatives died, that kind of stuff.
Good. Yeah, that's good. So growing up, did you kind of know, like, well, I'm going to be in the medical field, like that's my path? Or did you kind of think about doing something else at some point?
Pretty much. I was always interested in science, and medicine honestly seemed the most applicable. Wasn't that crazy about math, so being an engineer was kind of out.
Yeah. How'd you end up in West Virginia?
Work. My wife and I were living in Tucson, Arizona when we got married. We moved to Denver for about 5 years. Practice really didn't work out very well, and ended up being recruited to a practice here in West Virginia. And here I am 23 years later.
Shoot, yeah. Well, welcome. We need people, sir. And we need good people like yourself. So you're at ARH?
No.
Or no, that's old. Okay, you used to be at ARH.
No. Okay. I came to the cancer center here.
Oh, gotcha.
When it was the Raleigh Regional Cancer Center, Carl Larson Cancer Center. It's now been bought by CAMC, so I'm a CAMC employee.
Oh, okay. Yeah, see, I don't keep up with it, so I'm glad you clarified there. So what's your daily life like now? Do you see patients, or, what's the normal day for you?
Normal day, usually start seeing patients around 8:30 or 9, usually finish up around 4 o'clock, finish up paperwork, usually out by 5.
Gotcha. What's the typical, appointment like? Is it chemotherapy or,
Well, not for me. Okay.
Mm-hmm.
So a typical new patient will come into me usually with a biopsy and some x-ray studies, and whoever has done the biopsy has decided that radiation might be appropriate, and I talk to the patient, examine them, review their pathology, review their x-rays, decide whether or not radiation is likely to do them any good, decide whether or not combining it with chemo is a better idea, and go from there.
Cool. So we'll talk about treatments here in a second. I want to talk about cancer specifically. What's a basic understanding of what exactly it is? We know we hear different body parts and then you hear cancer after it, but I'm just curious if there's a commonality amongst the diagnosis.
I guess the best way to describe it is you understand that pretty much all the cells or most of the cells in your body are constantly regenerating. Skin wears off, it heals, intestinal lining of your mouth, lining of your lungs. And as these tissues regenerate, they have intercellular signals that tell them to stop growing. Okay, you've covered up that wound, you can stop growing. With cancer, something has gone amiss with those signals. So cells that are dividing to deal with a wound or some sort of injury just keep growing.
Okay, so basically bad cells keep multiplying and over time they start doing damage.
Right.
Yeah, okay. Why are some fast acting versus those who are, kind of slower or dormant? And feel free to be like, you don't know what you're asking. So like, tell me if I need, if I don't word it right, but.
Okay, certain types of cancer, just by their nature, are highly aggressive. Like, I'm sure you've heard of melanomas. Those tend to be fairly bad actors. I'm sure you've heard that prostate cancer, people generally die with cancer rather than of prostate cancer. And so that's a relatively slow-growing cancer. A lot of what you might be referring to has to do with how advanced the cancer is when you find it. You can imagine that if you had a skin cancer the size of a match head on the tip of your nose, you'd see it when you brush your teeth and you'd be aware of it pretty early. If you had that same skin cancer, that same cancer the size of a match head in your lung, you'd never be aware of it. I mean, it's not uncommon to have somebody come in with a cancer the size of a softball in their lung, and they're just starting to become aware of it. And by that time, the cancer's grown enough that it's often spread to some of the lymph nodes in the chest, spread to other organs in the body, that kind of thing.
Yeah, I've heard of people like, well, I went along in life like normal, and all of a sudden I couldn't urinate. And then they have this mass that they didn't even necessarily know was there.
Sure.
And I guess that's where let's talk about stages first. So you always hear stages. What exact stages are there of cancer, like from the beginning to the end?
Okay, so the whole idea behind staging is so that you can compare apples to apples and oranges to oranges when you're evaluating patient prognosis or treatment. And typically we look at three things. We look at the primary tumor, where the tumor started. And that's what's called the T stage. Depends a lot on the size, and also for certain specific areas, it depends on exactly where the tumor has spread to. Second thing we look at is what's called the nodal stage, which typically is determined by how many lymph nodes were involved and which lymph nodes. So basically, if you have lymph nodes that are close to the cancer that are involved by cancer, that would be a lower nodal stage than if they're more distant from the primary tumor.
Got
And finally, you have M stage or metastasis, which represents cancer that is spread to other organs where the cancer did not originate in, spread to the lungs, liver, bone, brain, that kind of thing.
Gotcha. So mortality rates, like, is it possible to beat any stage, like to overcome and go in remission? Or is there like a certain stage where it's kind of like you just make the patient comfortable? Or
one thing that you have to understand is that not all stage 1 cancers are the same, not all stage 4. So, for example, if you have a patient with stage 4 lung cancer, that usually means that it's spread to other organs, and almost certainly they're going to die. On the other hand, you can have people with stage 4 throat cancers who can be treated and have a 50% survival probability. So just knowing the stage doesn't tell you that the person is terminal or not. You have to know stage and the type of cancer you're dealing with.
Gotcha. So there's a lot of factors to kind of add in there.
Mm-hmm.
Okay. And there's no 100% mortality rate. Like it's all, I mean, of course it goes, is there a percentage for each type? Do you kind of evaluate and say, well, because you always hear people say, well, they gave me 6 to 12 months.
That's a guess. I mean,
yeah,
everything boils down to ranges. Depends on person's underlying condition. You have somebody who's a diabetic who's missing a couple of legs and he's on oxygen around the clock. No matter what type of cancer he has, he's probably not going to do as well as the guy who's running marathons. Okay.
Sure. What about a diabetic who runs marathons? Then we got another factor.
Yes, we do.
Because I was gonna say shout out, but I didn't feel it was because I'm a diabetic. I don't know if you know. Oh, okay. But yeah, go ahead. I'm sorry to interrupt you, but yeah. So it depends on quality of life that you're having.
And well, not so much quality of life, but how well they can tolerate the treatment.
Gotcha.
Doing radical surgeries takes a lot out of you, as does radiation and chemo. And if you're in pretty close to perfect health, you're going to do better than somebody who's not doing so well. The other thing is that there's just a lot of idiosyncratic reaction to various treatments. I mean, I've seen some people have almost miraculous responses to various chemotherapeutic agents, which have had absolutely no effect on other people with ostensibly the same type of cancer.
Yeah. It's weird how that works. Because I feel like, we got an iPhone 17 coming out. It's like we haven't figured this out yet. But at the same time, I know there's a lot of things that we don't necessarily know that you deal with probably every day. So what is typically here in Southern West Virginia? Is there a typical cancer that occurs more than others, or is it really sporadic?
Well, as I'm sure you know, the prevalence of smoking is really high in this area. And for that reason, we have a lot of tobacco-related cancers, in particular lung cancer, but also throat cancers, bladder cancer, pancreatic cancer. As you also know, I think West Virginia typically scores number 1 or number 2 in terms of obesity, and there are a number of cancers which are also related to obesity, breast cancers, endometrial cancers. So those tend to be fairly high in this area.
Sure, yeah. And obviously, you live a healthier life, your chances of getting cancer go down, but it still isn't zero. So what is there a percentage you would say of healthy versus unhealthy that come in, or is it, I know you mentioned smoking and obesity. A lot of people love food in the state. A lot of people love cigarettes. But is that typically the majority of what you see, or do you have some patients that are?
I mean, I'd say the majority of the people that I see have either breast cancer, prostate cancer, lung cancer, throat cancer, colorectal cancer.
Gotcha.
I guess the other one I left out was prostate cancer, which is kind of an unusual one in that it is so common. I remember reading a study. They did autopsies on young soldiers who had died in the Korean War. So they're in their roughly 20s. And there was about a 20% risk of finding undetected prostate cancer in the autopsies. You take 70-year-old guys, and you'll have about a 70% probability of finding undetected prostate cancer. So the way I look at it, it's about 1% per year. You may never know about it, may not affect your lifespan, but it happens. But in a small fraction of these people, something causes that prostate cancer to take off and start to cause problems. But like I said, if you did autopsies on your typical person who dies of a heart attack, stroke, whatever, in men, you're very likely to find prostate cancer that was completely unexpected.
Glad you brought that study up, because I remember hearing that of well, it's not going to kill them if they lived till they was 120. So it's not going to make sense to really treat it because they're going to be miserable. and it's not really going to be an issue. So thanks for bringing that up. So let's talk. I'll kind of walk through each one, and we'll talk about symptoms. So let's just say colon cancer. Are they typically like this? Do people typically find them when they have some kind of scan and not knowing about it, or is it very symptomatic?
Probably the earliest symptom of colorectal cancer is bleeding. Problem is, it gets mixed in with stool, and I don't think a whole lot of people spend a lot of time studying their turds in the toilet bowl. So they've come up with a number of tests that chemically examine stool for blood. There was the old Hemoccult test, which was done with your finger. Now they have Cologuard tests where you actually collect a stool sample and send it in. I think it's a DNA test. And that's just an indication of is there blood or not in the stool. And that's a good indicator, but it's not a guarantee there's colorectal cancer. And so if you have blood in your stool, the next step is to do a scope, which allows you to actually see the tumor and to get biopsies.
Gotcha. There's a stigma with pooping in a box. Come on, people. We got to be okay with it. Like, I've had to do it. Typically, you're probably going to have to do it if you're here long enough. So just do it, and let's be safe. So, so if someone does experience, is it like, can sporadically, is it really heavy bleeding when you should go, or is it kind of like?
Well, if you see it, you probably should call it to your doctor's attention. Now, it may be that you have hemorrhoids and they check out once. Well, it's probably hemorrhoids again. That can also give you a false sense of security, because people who have a history of hemorrhoids can also ultimately develop colorectal cancer. So you don't want to blow it off and say, oh, it's just those hemorrhoids we know about. But my point is that a lot of times the blood is so scant you won't even see it. And that's why they do those screening Cologuard tests. That's why they do screening colonoscopies.
Gotcha. And I've said dumb stuff on here. I was like, I think blood's like half, or I think poop is like half blood. And I was like, that's completely wrong. So I just spout random stuff. So y'all listen to him. But that's good to know. So, and what a hemorrhoid exactly, like, is it basically a lump that forms in your colon? Like, what is a hemorrhoid? I know you have external and you have internal.
Do you know what varicose veins are?
Yes. Like, I've seen them in people's feet a lot of times. Yeah.
They're basically varicose veins of the rectum.
Okay. And they just clot up, or?
They swell up. They get irritated. They can clot. Yeah.
Gotcha. Okay. Well, that's good to know. So as far as lung cancer goes, is coughing up blood, I imagine, is a really big symptom.
That's a symptom that, like colorectal cancer, it is generally not symptomatic when it's early. And it's been very hard to screen people for lung cancer up until maybe the past 10 years, when they came up with the low-dose screening CT scans, which have been pretty good at detecting early cancers. The problem with lung cancer is that generally, by the time it's big enough to cause coughing, bringing up blood, shortness of breath, chest pain, or to even show up on a plain old chest x-ray, it's often advanced beyond the stage where it can be reliably cured. And that's why they've been working on these low-dose CT scans, which can be done annually on people with a heavy smoking history, and which have been pretty good at identifying relatively small and therefore curable cancers.
Gotcha. You say low-dose CT scans. What is low dose? What does that mean?
Any kind of X-ray will expose you, or any kind of X-ray procedure will expose you to X-rays. And CT scans actually have a fairly significant radiation exposure. And so if you're going to be scanning somebody every year, you'd like to minimize the amount of radiation exposure. And that's what the low-dose CT scans do. They're fairly low resolution, but they're good enough to identify small cancers.
Gotcha. Is there something I could do? Like, I could just set up an appointment and say, I want a full body tumor check. Like, is there something you can do there?
A full body tumor.
Or just like, I want checked for every cancer. I mean, do they just offer that, or is it mainly you can't go until you have a reason?
Well, I mean, you go to the Mayo Clinic and you want to get an executive physical, they'll put you through the head-to-toe CAT scanner. Generally not particularly cost-effective. I think they're coming out with some blood tests which try to examine circulating tumor DNA to try to act as a screening test. These are not yet approved for routine clinical use. It's a great idea, but at this point, it's not really viable. Right now, the screening that we have is pretty much directed to specific organ sites: Pap smears for cervical cancer, mammograms for breast, PSA for prostate, screening CT for lung, colonoscopy for colorectal, that kind of thing.
And I imagine most insurances wouldn't cover you to go to the Mayo Clinic and be like, all right, boys, hook me up.
No, you'll be paying about $3,000-$4,000 out of
$3,000-$4,000? That's actually way lower than I thought it'd be.
Really? Okay.
All right. That's good to know. So pancreatic cancer, like I know what a pancreas does, and I know mine doesn't work real well. What does that typically feel like? Do you have certain type of pain, or?
That's another one that does not give you symptoms fairly early on. Typical people find out they have pancreatic cancer typically either if they start to have pain as the tumor kind of grows posteriorly into the posterior abdominal wall, or because your bile ducts from your liver into your intestines pass through the head of the pancreas. If you have a tumor growing there in the head of the pancreas, it can block off the bile duct, which will cause the bile to back up, and that you'll appear jaundiced.
So constipation would be a possible symptom?
Jaundice usually is the big one.
Jaundice. Okay. And that's where your skin turns yellow? Gotcha. Well, so far, Doc, we're not easing a lot of people's minds out there, but we got to have the truth. We got to know these things.
But I brought my rubber gloves in case you need an exam.
There we go. Okay. Good deal. So stomach. Is there certain issues with your stomach, like maybe heartburn? Is that a sign? Different things like that.
Cancer of the stomach itself used to be really common back in the 100 years ago. And the incidence of that has dropped dramatically. And I'm not really sure of the reason for that. I've read stuff about that it might be related to changes in the way we preserve food, less smoking, more refrigeration and freezing, that kind of thing. But what we are seeing more and more of is what are called cancers of the lower esophagus, or cancer of the esophagogastric junction. That's where the esophagus plugs into the stomach. And these types of cancers are becoming increasingly common. I mean, I've only been doing this for about 50 years. And when I was a medical student, it was not too common to see this type of cancer. And at this point, it's actually a pretty common type of cancer. And it's probably related to reflux and heartburn. Why that's been increasing may have to do with increases in population obesity. The other thing I've always been a little bit concerned about is whether some of these anti-heartburn medications that we use, like proton pump inhibitors like omeprazole or Nexium or Zantac, might in some way alter the gastric content so that when you reflux it, it's more carcinogenic. I honestly don't know the answer, but I do know the epidemiology has changed just in the period of time that I've been working.
Gotcha. So mouth cancer, we like to choose skull in this neighborhood. Do you see a lot of mouth cancer come into your office, or is it?
Cancers of the mouth per se are usually managed surgically, but we see a lot of throat and laryngeal cancers, and those are usually smoking related.
Gotcha.
The other thing is, I'm sure if you have a daughter, you probably they've talked to you about HPV
Mm-hmm.
immunization. And in addition to causing cervical cancer, that virus can also cause throat cancers. And so there's been a fairly big increase in the number of non-smokers who are getting throat cancer due to the papillomavirus.
Oh, wow. Okay. So, and we can talk about this. We're all adults. Is that through like oral sex? Is that kind of how that works? Because I've heard of this.
That's the way I'd put it together.
Okay. Gotcha. Well, that's good to know. But you mentioned there's a vaccine.
Yeah.
Okay. What is it called?
Oh, a minute.
Won't hold that against you if you can't remember. But if you have a daughter, look into it.
Right.
Decide for yourself.
And a son at this point.
Okay.
Knowing what we know about it. Yeah.
Gotcha. All right. Well, that's good to know. So in one we always hear about, which is so important to keep talking about, has its own month, breast cancer.
Right.
And that's one of the few that you can actually do regular checks at the house. Tell me about that one. How does that?
Okay.
How does it work?
Well, you mentioned getting checks at the house. At this point, mammography is so good. It's pretty rare that I see somebody who says, I found a lump. Usually it's just a screening mammogram that brings them in.
And that catches it earlier.
And as some of the technology has advanced with the digital mammogram, requires less and less radiation exposure.
Yeah. Okay. But the check, I mean, you like raise the hand and then you feel.
Right. Because about a quarter of the breast tissue kind of goes up into the underarm area.
Okay. I got you. And basically, if you feel something that ain't supposed to be there, go to the doctor. And so do you see a lot of men that actually get breast cancer? I've heard of cases of men getting it too.
It can happen. It's not real common.
Gotcha. Very uncommon. All right. So, let's talk about bladder cancer while we're at it. You mentioned that's one of the more popular ones out there. What are the specifics there on what that is exactly?
It's in this population, smoking related. There are also some other causes of bladder cancer. If you live in the Middle East, there are certain parasites that colonize the bladder that can lead to bladder cancer. I don't think that this is an issue any longer, but in the past, certain people who worked in certain chemical industries had a high risk of bladder cancer. But I guess the final common pathway is all three of those things I talked about irritate the lining of the bladder. And like I said, cancer is basically kind of it's a reparative response gone wild in a sense. Mm-hmm. And typically people with bladder cancer will either have discomfort when they urinate, burning, or more likely blood.
Gotcha. When should we freak out, doctor? Like, is it something that for me, I try to listen to my body and I'm like, wait a minute, that's really not correct. And then but also I'm a spaz. Mm-hmm. So I'll be overly precautious sometimes. But to me, it's like, well, I'd rather be that than not. But what's some comfort you can give people? Well, if any.
Avoid tobacco products. Any bleeding that shouldn't be there, which would mean coughing blood in your stool, vaginal bleeding in a postmenopausal woman, any unexplained lump. Those are probably the big ones.
Okay. What's menopause? Like you got pre, post, and during? I don't know the words, but okay. What is it exactly?
Menopause?
Yeah.
Okay. So, most girls typically in their 12, 13 years age, they start to cycle regularly. And menopause usually occurs around age 50 when the women stop cycling.
Okay. So is it like lack of hormones, things like that?
Yeah. Basically, their ovaries no longer produce estrogen.
Okay.
Or produce a very low level of estrogen.
All right, which causes different things like fatigue and
hot flashes and weight gain, hair loss.
Gotcha. Well, that's good to know. I've always heard the joke like, "Oh, I'm in menopause." I'm like, I don't really know what that is. But that's good to know. So as far as treatment goes, you're specifically, so you got chemotherapy and your radiation, and those are different things.
Yes.
And you got surgery.
Right.
Are those the three, or is there some kind of experimental stuff out there we don't really know about, can't do yet?
Pretty much anything that involves drugs is done by medical oncologists. Anything that involves any type of radiation will be done by radiation oncologists. And anything that basically involves physically removing or doing something to the cancer will be done by a surgeon.
Gotcha. Well, when they decide to do surgery, is it where they're like, okay, well, we know it's right here in this certain section, and we know we can remove this and the recovery won't be too dramatic? Mm-hmm. Is that basically how they narrow down?
Yeah, they look at where the cancer is, how big it is, where the cancer is likely to have spread to, if the cancer can be removed without causing too much disability, what kind of reconstruction or rehabilitation is available, that kind of thing.
Okay. Is the goal, like, if you got it in several areas, obviously you can't do surgery on it yet. Would the goal be like, do y'all come together and are like, okay, well, we're going to try this for 6 months. We're going to try this, do you kind of step it out like that?
Very often, yeah. There are tumor boards where you'll get surgeons, medical oncologists, radiation oncologists, pathologists, radiologists getting together and talking, once a week, once a month about patients they've seen, trying to plan out treatment. I work in the same office as my partners who are medical oncologists, so we cross paths in the hallway all the time and talk about, what are we going to do with this one? Let's try this for a while. If these conditions are met, let's do this. Otherwise, we'll do that.
Okay. So y'all collaborate a lot.
Yeah.
Okay. And you trust your fellow professionals. Do y'all go golfing together or anything? Like, hey, guess what I did today? Or, is it kind of not a lot of jokes?
I'm not a golfer.
Okay. I got you. I'm just curious if like, oh, y'all meet at Cracker Barrel on the weekends and say, yeah, you better not change this logo, boys.
No, mostly in the clinic.
Okay. Gotcha. What's your hours like every week?
It's usually like 8 to 5.
Oh, okay. So it's not like you're not on call or anything, or
my work is 100% outpatient because in order for me to do my work, I require a machine that costs several $1 million and needs to be shielded with feet of concrete in all directions because it generates high energy X-rays. Mm-hmm. And I can't put that machine on my back and take it to the hospital. So anybody who I'm going to treat has to come to me.
Yeah, well, that makes sense. Let's talk about radiation. So what's the basic idea of it? I'll tell you what I think. I don't know. So you zero in on a target, and then you push all this energy into this one place, and you kill stuff to have it regenerate, hopefully healthy. Is that what happens?
That's a pretty good description.
Okay. Well, sweet. Well, you give me the actual professional description.
Well, I mean, that's pretty much it. Based on X-rays and examination and the known behavior of that particular type of cancer, you can figure out what needs to be targeted. You look at the anatomy and see which other normal tissues are in that area and need to be protected. Mm-hmm. You have a pretty good idea of how much radiation you have to give the cancer in order to control it. You have a pretty good idea of how much radiation the normal tissues can tolerate before they are injured. Mm-hmm. And you basically go from there.
That's good to know. So what's the symptoms of the typical symptoms someone goes into when they get regular radiation? Are they like, I know chemotherapy, it makes you nauseous. Does radiation do that stuff too?
Radiation is symptoms are toxicity from radiation is more anatomy specific. So, for example, if I'm treating somebody's prostate, they may have some symptoms of bladder irritability, like urinary frequency or burning. They may have some symptoms of rectal irritation, like looser or more frequent stools. Whereas if I'm treating somebody's throat cancer, they will have difficulty or discomfort swallowing. They may have some hoarseness. They may have some loss of taste. They may have some loss of saliva. So with chemotherapy, it's more general because it's introduced into the bloodstream and kind of the drug goes everywhere, no matter which drug you're injecting. Whereas with radiation, you're pointing it at a specific part of the body.
Okay, that makes sense. What's the typical span of radiation treatment? Do you have a certain set of months?
I'd say probably the majority of patients we treat are completed in 5 weeks or less.
5 weeks or less.
And there's some that take 7 weeks or so. Sometimes if somebody has terminal cancer and we want to treat them very quickly so as not to inconvenience them, take them away from their family, we'll give them 1 or 2 treatments.
Okay. Do you have a certain success rate, or do you get hyped when you're like, yeah, we really kicked that cancer's butt this time, or do you got to stay level headed of okay, let's look at the data. Here's what the solution may be. Well,
sometimes you wouldn't know you'd kicked the cancer's butt till a couple of years later. So it's not like you can spike the ball in the end zone. It's kind of like you throw the Hail Mary pass, and then 3 years later, you know whether or not the receiver caught it or not.
Yeah. You ever had a patient come back years later and be like, doctor, I just want to thank you, or the contrary? Anyone ever get upset, or I'd say there's a lot of emotions in your type of work.
Oh, sure. Both.
Yeah. Do you stay level-headed, or are you like, you know what, I did good today. Today was a good day. Or are you just like, I want to just do what I can, retire one day and watch the news when I get home and come back and do it all over again? I'm just curious what you do for fun.
Oh, what do I do for fun?
Yeah.
I have kind of an unusual hobby.
Okay.
I do Brazilian Jiu-Jitsu.
Oh, wow. That's awesome. Are you up here? What is it? They have that one place.
You know Chris McKinney?
Yes. Okay. Arte Suave.
Mm-hmm.
Okay. How'd you get into that?
Well, I used to lift weights a lot, and I started when I was before I was a teenager.
Mm-hmm.
And so I did not have any particular training, and I used to lift way more than I should have. And after my 5th shoulder operation, which was a rotator cuff repair, I was telling myself, I need to stop doing this. Otherwise, I'm really going to destroy my body. And I was driving down Prince Street, and the gym was there. I was thinking, why don't I give that a try? I'm not getting any younger. So I was nearly 63 when I started.
Heck yeah, man. That's awesome. So, what belt are you up to?
Brown.
Wow. So if someone runs that mouth at work and they try to throw hands, it may be a bad idea to run into Dr. Shimm. I'm probably going to you to be like, get this guy out of the lobby. Possibly. Okay. It just depends on how big a boy it is. That's awesome though. Mm-hmm. So how many times a week you do that? Twice?
4 or 5.
4 or 5.
Yeah.
Wow. Man, I feel really lazy. That's great though. Yeah, I've heard a lot of good things about that out there.
You need to get Chris in here and talk to him. He's kind of an interesting guy.
Yeah, man. I did kickboxing for 2 years.
Mm-hmm.
And I just was like, I'm not going to get kicked in the head anymore.
Mm-hmm.
I think I'm going to stop this, because I started getting headaches and stuff. And I was like, yeah, I love the exercise part of it. But I think where I was, they was sparring a little too hard. But yeah, man, maybe one day I'd love to figure out when I have more time to sort through that. That's awesome though. See, brown belt, black belt's next, right?
Mm-hmm.
Yeah, man, that's great. All right, so back to treatments. As far as chemotherapy goes, what's the basic explanation of that? I know that's not what you typically do every day, but it's a bag, IV, and
there at this point there are any number of chemotherapy agents. There are immunotherapy agents. What the chemotherapy does interrupts the division of rapidly proliferating cells. I guess that's the best way to look at it. And since cancer cells typically are dividing more rapidly than normal tissue, they tend to suffer a little more damage. And hopefully sort of in the interval between the different cycles of chemotherapy, the normal tissue recovers better. That seems to work.
Okay. Is there different concoctions of the drug? Or
There must be 30, 40 different chemo agents, and they're combined in different ways. And now there's immunotherapy, which kind of trains your immune system to fight the cancer on its own better.
Yeah. Have you ever had a patient decide you know what? I decided I'm not going to do anything.
Sure.
Really?
Sure.
And you respect that. You're like, well, okay.
Oh yeah.
You're right. Do you try to talk them out of it, or are you kind of like, well,
Depends. I mean, if it's a young person with a curable cancer, I might lean on them harder than if they were older and not in such great health. I mean, a lot of this is a big issue in dealing with, say, prostate cancer, where your population's fairly old and your cancer is fairly slowly progressive, and your treatments can have a lot of really unpleasant side effects. And I'll usually, go to the Social Security Administration life tables to get some estimate as to how long the person can be expected to live otherwise, and try to go over with them, here's what your natural lifespan is likely to be. This is what your cancer is like. It's very likely to cause you problems before that natural lifespan, or it's unlikely to cause problems. Here are the treatments that are available. Here are the possible side effects. And it can get kind of complicated, because in particular with prostate cancer, people can have a lot of problems after surgery. They can have a lot of problems after radiation.
Gotcha. Do you deal with insurance companies, or is that not your thing? You're just whatever. I'm just curious if they ever try to fight. I don't know. You don't need quite that many treatments.
Oh yeah.
Do they?
Oh yeah.
Okay.
Yeah. I mean, I'd say probably once a week or so, I'm on the phone with what they call a peer-to-peer conference, where I have to, they have physicians on their staff who, if they've rejected a claim, you can sometimes talk them into it.
Okay. So they have an advisory board of that sounds a little overkill.
Yeah, they have policies, and if you're doing something that does not adhere to their policy, you get the opportunity to speak to somebody and explain to them why you want to do what you want to do.
Gotcha. As far as cost goes, let's just say I'm out of pocket.
Mm-hmm.
How much would let's say mid-level stage, I don't know, what is that, stage 3, how much does that therapy usually cost someone to work towards remission? Is there a wide range of what it could cost, or
you're talking the pricing of medical services is bizarre, because it's so distorted by the fact that pretty much everybody has insurance, and they never see the price of the treatment.
Mm-hmm. Like the line items.
Yeah, because, I mean, for example, we might bill $100 for something. The insurance may knock off half of that right from the get-go. they may pay 40% of it, and then the patient might be responsible for 10% of it, or their secondary insurance will be responsible for the final 10%.
I gotcha. What's that typical 10% like? Like $10,000, $30,000? I'm just curious if there's a...
Kind of depends. I mean, I'd say I'm really kind of reaching here. I'd say for what I do, it'll probably be a couple $1,000s for some chemo drugs, which can run $100,000-$200,000 a year. It would be more. And fortunately, a lot of the drug companies do have patient assistance programs where they'll basically discount the drug.
Gotcha. Do you have some kind of like, well, this is a really young patient. I think there's this treatment available somewhere else that's a little experimental. I think they'd be good for it. Do you ever do anything like that?
Sure.
Where you say, try this place?
Sure.
What kind of experimental things are going on right now with cancer? Because, everyone's like, man, we ain't figured it out yet. Like, we haven't really figured this cancer thing out yet. Because the world constantly evolves, too, as does the cancer.
Mm-hmm.
It wants to exist, too, unfortunately.
Sure. There are always new drugs. And again, because chemotherapy isn't my area, it's not something I'm real familiar with. But my partners, if there was some promising new drug that was not yet FDA approved, but was, being investigated on a protocol, they would refer the patient to Morgantown, Ohio State, Duke, wherever, and get them on a protocol if it was available.
Gotcha. You ever like, hey, now in Tijuana, there's this little place like stem cells and stuff like that. Mm-hmm. What is your opinion on that kind of stuff? Which I don't know how much stem cells, how much they do involving cancer. I know they do for like hips and shoulders. Right. And
in certain patients who have refractory cancer, one thing that can be done is to give them what amounts to a lethal dose of chemotherapy. But before that, you can harvest stem cells either from bone marrow or from peripheral blood. And since most of the fatal toxicity from chemotherapy is related to the bone marrow, the blood, after that lethal dose of chemotherapy, you can then infuse stem cells, and those stem cells will take root, and the patient won't die.
Oh, wow. So, like, if I'm hearing that correctly, so you give them a huge shot of the juice, and you give them a recharge to keep them from going on. Okay. Wow. That makes sense. That's not in the U.S.?
Oh, yeah.
Oh, it is? Okay. So that's kind of an example of it. They don't do that in West Virginia?
Sure they do.
Oh, they do?
Yes.
Okay.
Yes. They were doing this when I was an intern.
Gotcha. Okay. What causes the hair loss?
Hair follicles are proliferating rapidly, and so the cells are damaged by chemo or the radiation.
Okay, that makes sense. So what is considered remission? Like, I think some people hear remission like, oh, it's not there anymore. From my understanding, it's basically like it's not growing. Is that what the definition of remission is?
I've never been really sure exactly what's meant by it. I guess you could say remission is if there's no visible evidence of cancer in your body, either on examination or on x-rays. However, with a lot of cancers, that's to be expected after their initial course of treatment, but not everybody is going to survive. So in some people, the cancer comes back, and I guess we say they were in remission until it came back. And in other people, the cancer never comes back, and we say, well, they were cured. But at that time, 2 months after treatment, you don't know he's in remission versus he's cured.
Okay. Well, I've always heard like when it comes back, it's more aggressive. Is that a thing, or is it kind of, like I've always heard like they was in remission for 5 years and it came back and then it was quick.
Yeah, well, Usually when we're treating people with drugs, we use the most effective and the least toxic drugs first. And generally, if a cancer comes back after treatment, it's going to be resistant to those drugs. So the only remaining drugs that can be used are the ones that are either less effective or more toxic. So the cancer is probably going to progress more rapidly.
Okay. That makes sense. Do you, which, 50 years later, I don't know, do you find yourself getting complacent, or are you able to just be like, this is an important job? Do you still enjoy what you do?
I do, yeah. Generally find something new to interest me about pretty much every patient I see.
Mm-hmm. Like, what interests you? Like, oh, that's interesting. I've never seen this happen, or different thing.
It can be that, or it can be that it's a unique individual. I mean, they've had an unusual life.
Yeah. Do you see a lot of coal miners?
Oh yeah.
Really?
Oh yeah.
So like black lung, or can that form into lung cancer?
It's not lung cancer, but it clearly affects lung function. So therefore, it affects the natural course of lung cancer among people with black lung who also have lung cancer. They're obviously not going to tolerate a lung resection as well, because they don't have as much underlying lung function. For the same reason, they're not going to tolerate radiation as well. Mm-hmm. And I guess another sort of idiosyncratic thing about black lung is that we use PET scans a lot to determine how far a cancer has spread, and black lung appears abnormal on a PET scan. It can masquerade as lung cancer. So if you have somebody with black lung and lung cancer, you can often end up wondering, is that abnormality that I see, is that the black lung, or is that the lung cancer? Sometimes you have to go in and get biopsies.
What's the difference between a PET scan and a CT scan?
Okay. A CT scan is basically a glorified X-ray. Does some computer processing, but it's basically done with X-rays. Your standard FDG PET scan is done by injecting people with a radioactive glucose. Okay. And cancers are they're gas guzzlers. They suck up a lot of glucose. And so what the PET scan does is it uses a camera, and it identifies the uptake of that radioactive material as it's examining your body. So if you have a cancer, it'll concentrate a lot of that FDG glucose, and it'll appear bright on a PET scan.
Okay. That makes sense. How many patients would you say you saw over the years? I mean, thousands?
Yeah, I was trying to figure that out. I figure probably about 300 to 400 a year times 50 years. So
wow. So I'm trying to do math. 15, what is that? 15,000?
Yeah.
Somewhere in there?
Yeah.
Wow. Man, that's crazy. All right. Well, I think we covered the basics of all of the cancer. I do wonder, have you ever choked anyone out? Have you been hey, Chris, put me in a headlock and choke me out. I want to see what it feels like.
We do that to each other every evening.
Okay. So what's your favorite submission? Do you have one? So you got the arm bar. So I'm sure you know that.
Oh yeah.
That's pretty basic.
Yeah. I'd say rear naked chokes or guillotines or Munson chokes.
Okay, and you got the triangle.
Mm-hmm.
You got what's the omoplata?
Omoplata.
I'm trying to think of some of the more
Americana. Then you get your leg locks. Yeah.
Do you watch UFC?
Not really.
Yeah, you're right. So jiu-jitsu is more like a puzzle to me. Mm-hmm. It sounds like you got checkers, which is punching and kicking people in the face. Then you got chess, which is jiu-jitsu to me. Mm-hmm. It's like you're figuring out this game of how to beat this other person in this puzzle. You know what I mean? I don't know, but I've only done it I've only grappled a few times, and you can tell the difference really quickly with someone who's done it.
Mm-hmm.
It makes you feel like you're completely useless. It's like, oh, I thought I could somewhat defend myself, and I'm completely flipped upside down. I better get a can of mace because it's going to be a problem. So yeah, how long did it take you to get into the swing of things?
Oh boy. I guess the first couple of months I was just getting smashed, but kind of got comfortable being uncomfortable. And after that, you can kind of learn to work your way out of situations.
Yeah. You didn't get hurt?
Oh God. In one 21-month period, tore my left rotator cuff, tore a meniscus in my left knee, tore my quadriceps tendon in my right knee, had to get a redo rotator cuff repair in my right shoulder, and I had MRSA sepsis, and I was in the hospital for a week and had to be on IV antibiotics at home for a month.
Goodness gracious.
Well, not really. I was going to work, and I was hooking myself up to the IV bag while I was at work.
Was you really?
Yeah.
Benefits of the job. I mean,
Yeah.
Wow. MRSA, and was that like a continuous infection, like a really bad?
It's a staph infection that is resistant to sort of the common penicillin antibiotics.
Gotcha. Wow. So safe to say, yeah, I've had a couple injuries. Wow. So I got this thing going on my shoulder. I got to ask you, Doc. So when I do a certain move, there's something in here. Like if I slice a golf ball, like come over the top, it feels like I got shot with a shotgun. And then it just goes back. Like I can do push presses, I can do things like that, but it's that one move, and I'm not exactly sure what's going on. So if someone's listening and let me know. But
I mean,
is that kind of rotator cuff stuff?
The shoulder is probably the most complicated joint in your body. So I mean, it could be plain old osteoarthritis, could be a labrum tear, could be one of your rotator cuff muscles.
I'm just hoping it heals. Like just feel better, and then I'll be doing good for a while, and then all of a sudden, bam, there it is. It's usually in golf when I do it, like repetitive injuries. A lot of people, like how, I don't know, so most people your age are like, let me go play pickleball. You're like, let me go and get body slammed and, try not to pass out today. But a lot of people blowing ACLs thinking they can get out there and do all this movement. And I think I read like pickleball alone increased medical expenses by like $400 million or something last year. Yeah, something crazy. But I'd say jiu-jitsu is pretty low when it comes to like, and not that you're old, but I mean, 63, you don't think of a lot of people going out to start jiu-jitsu. That's awesome. All right, Doc. So, final thoughts. What would you like to say to people out there as far as cancer goes and how it affects West Virginia and how they can be proactive?
I'd say take responsibility for your own health. Wear your seatbelt. Don't drink much. Don't smoke. Watch your diet.
Heck yeah, and diet, obviously Chick-fil-A, Lord's Chicken good for people or no?
Just don't eat too much of it.
Okay, don't. That's my thing. I'm like portion control.
Yeah.
I try to stick to like a handful, and that's kind of the way I live my life. Like I want to live too, but at the same time, you got to be responsible.
I think you can get really wrapped around the axle about diet. I mean, and you can talk to some people and they have almost a religious intensity. You've got to do keto. You've got to do intermittent fasting. You've got to do a Mediterranean. I think really, unless you have a really, really crazy diet, as long as you watch your calories, your macros will probably be pretty balanced. Okay. Now, clearly, somebody like yourself who's a diabetic, somebody with kidney failure, they have to be a little more careful about their diet. But yes, somebody who doesn't have a chronic metabolic problem, like I said, keep your calories okay, and unless you have just some sort of really, really outlandish dietary habits, your macros will be okay.
Yeah. I'm noticing I can't go as crazy as I used to. Like some days, man, my sugar's just, I'm like, why can't it be controlled today? I think it's a variety of reasons.
Well, I mean,
but
that could even be your emotions can make your sugar go out. Yeah.
Dude, it's been a stressful week. I think that's a large part of it, but that's good to know. Well, cool, Doc. I mean, what do we plug? Do you get referrals, or how do people make it to you?
How do people make it to me? Typically, they will have a biopsy. Somebody will tell them they have cancer, and more often than not, they'll be referred directly either to me or one of my partners, or occasionally, if they may be seen up in Morgantown or in Charleston or someplace, but they come from here and they'll say, "Yeah, I know you can treat me up in Morgantown, but I really don't want to be living 3 hours away from home for 6 weeks."
Yeah, it makes sense. Well, if with all due respect, I hope people don't have to see you, but if you do have to see him, you're in good hands. So, and watch him hands too, because Dr. Shimm don't take no crap. But well, thank you, sir. We'll close it out here. So everyone else, be sure to, if you like this video, be sure to like it and subscribe to Creepalachia on YouTube if you haven't. If you're listening on Apple or Spotify, take a minute and leave a review. That'll really help the show be found. If you've suffered cancer, or you have a cancer experience, I really want to talk to you about it. Be sure to email me at creepalachia@gmail.com. I think it's important we talk about this stuff because, talking about it helps you figure out how to beat it. And, I know this is a very sensitive subject for many out there. So thank you all for taking the time to listen. And last but not least, always remember, above all else, long live Appalachia.